Today I'm talking about interoceptive exposure therapy for panic disorder and agoraphobia. Hi, I'm Paige Pradko. Welcome to Therapy for a Better Life. I have a young client who actually has a full-blown panic attack every time she goes up or down the stairs. So what do you think is happening there? Do you think that she's afraid of stairs? No, that's not actually what's happening. She has panic disorder and agoraphobia, and every time that her heart rate increases, her brain interprets that as that she is in danger, and her brain initiates the sympathetic nervous system and has a full-blown panic attack. This is the case for people that are diagnosed with panic disorder. Their panic is initiated by internal body sensations, internal cues, and the internal sensation is wired together in the neuropathways with the fight or flight system. It's wired with the amygdala. The amygdala gets activated and initiates this sympathetic nervous system response, the fight or flight response. So panic attacks can actually be triggered by external cues or internal cues. Now, external cues are anything external to the body. So they include things in the environment, like maybe somebody triggers a panic disorder anytime that they are in a grocery store. That's an external cue. Or, a person may have a panic attack when they see dogs, if somehow their brain has learned that dogs are dangerous. They had a bad experience. It may be triggered by being in social environments or crowds, or for some people it's driving in a car or driving over a bridge. All kinds of external cues can trigger panic attacks. There are also internal cues, as I said, internal body sensations that trigger panic attacks. They can be a whole number of different things, like increased heart rate or difficulty breathing or shakiness or sweating or derealization. All kinds of symptoms can actually initiate a panic attack. So what we do about external cues is we can do traditional exposure therapy to external cues. For internal cues, internal triggers, internal body sensations, we use an exposure therapy called interoceptive exposure therapy, and that's what I'm describing today. So for interoceptive exposure therapy, we set up specific exercises where we are exposing the client to the same body sensations that trigger their anxiety and panic. So if a person, for example, their heartbeat, like the example I gave in the beginning, their increased heart rate actually triggers a panic attack, we are going to, first of all, get approval from their physicians to do these exercises. That's important. But then we go right into recreating the sensations of increased heart rate. In that case, we're going to have them maybe run in place for 1 minute, and then we're going to have them rest for 1 minute and repeat that 8 times. If their sensation that causes a panic is dizziness, we might have them going on a swivel chair and doing that slowly for a minute, resting for a minute, repeating that 8 times. If their trigger is breathlessness, we're going to have them possibly hyperventilate or breathing through a straw. And I have a whole list of exercises, and I'm going to leave you actually a link in the description of all different exercises published by University of Michigan for interoceptive exposure therapy based on what particular body sensation triggers your anxiety and panic attack. But I'm going to run you through an example of actually using interoceptive exposure therapy. And this particular client, their trigger was dizziness. She, in fact, said that she didn't really know what brought on her panic attacks, but the first sensation she would have is a kind of a dizziness, and then that would make her anxious, and then would come the full-blown panic attack. So we decided to work on dizziness. Now, step one is just identifying that trigger, that internal cue that triggers the panic. So dizziness in her case. Step two is we're going to create a fear hierarchy, where we are going to list a number of different exposure exercises, and she's going to give each one of them, each exercise that creates dizziness, she's going to give them a SUDS score. SUDS is SUDS. It stands for Subjective Unit of Discomfort Scale, and it's from 1 to 100 on how uncomfortable is she to practice this exposure exercise. So she had 4 different exercises, and she created a hierarchy. The first exercise was sitting in a swivel chair and slowly spinning for a minute, resting for a minute, repeating that 8 times. She gave that a SUDS score of 80. The next one was shaking her head side to side for 30 seconds, resting for 30 seconds, repeating that 15 times. She gave that a SUDS score of 70. Then she sitting straight in her chair, putting her head between her knees for 30 seconds, lifting it up for 30 seconds, repeating that 15 times. That was the next exercise. That was a SUDS score of 60. And then finally, hyperventilating. This was shallow breathing, 120 breaths per minute. And she would breathe like this for 1 minute, take a rest for 1 minute, repeat that 8 times. Hyperventilating is shallow breathing, kind of like, that's the type of breathing. And she gave that a SUDS score of 50. So the next step is actually starting the exposure. Now, doing the exposure, she started with the one that was the easiest for her, or the least comfortable, and that would be the one with the SUDS score of 50, which was the shallow breathing. So she practiced this every day for a week. And as she went through the exposures, she had to give herself a beginning SUDS score rating every day, every time she practiced the exposure. What was her SUDS score? At first it was 50. As she kept going through the week, it kind of came down a little bit to 45 and 40 and 30, and then she had to give it an ending SUDS score. So every day the ending SUDS score was a little bit less anxiety. She had a little less anxiety after the exposure. So her brain was beginning to learn that this dizzy feeling was not dangerous, and that rewiring was beginning to take place. Now, the next step is that as soon as she wasn't able to get any more anxiety, she started these exposures, and she was at almost a 0 through 10 or 20. She wasn't able to get any anxiety going with this anymore. It meant that she had completed that exposure, and it was time to move up on her hierarchy and start the next exposure. And so she would start the next one. As she was going through her exposure therapy, and this was going on for weeks, I was encouraging her to continue to make herself anxious, because your brain has to be anxious in order for the exposure to work. So when her SUDS score was coming down, I would say, how could you make yourself more anxious to get that SUDS score to come up again when you're doing the exposure? Could you try the exposure in a different environment? Could you add some fearful thoughts about maybe the dizziness will really create a panic attack, and try to get yourself anxious? Let's get the most effectiveness out of the exposure that we can. And she actually completed her hierarchy in 10 weeks. And at that time, she really couldn't get any more anxiety out of being dizzy. She had completely created a new neuropathway in her brain that being dizzy was not associated with fear anymore, and therefore did not create panic. So I want to say a few more words about panic disorder. And when you're doing exposure therapy, this interoceptive exposure therapy, or any type of exposure therapy, Your brain has to be very anxious in order for exposure to work. It's called activate to generate. We have to activate the amygdala, get our fear center very anxious for the new neural pathway to be formed. If we do an exposure therapy and we're not anxious, it doesn't do anything. So you have to be anxious, activate to generate those new neural pathways. You want to start gradually. You want to work up the hierarchy. It's okay if you want to flood yourself and do something, go to the top of your hierarchy first. In fact, that actually creates healing a little bit faster. Most people like to work up gradually. You want to challenge yourself as you go. Challenge yourself in different environments. Even though you're doing interoceptive exposure therapy on internal body symptoms, you want to try to keep challenging yourself and increasing that anxiety by doing it in different locations and adding anxious thoughts to really make it intense for yourself. No safety behaviors. We don't want you taking medicines or having medicines with you, or having people with you, or checking out the local hospital, or doing anything to kind of, checking your body's symptoms or your heart rate. We don't want any kind of extras like that. Take off those Apple Watches. We don't want anything that is checking your heart rate for you. That your brain knows that's a safety behavior, and it makes the exposure therapy less effective. Other things that make exposure therapy less effective is any type of asking for reassurance or Googling symptoms or taking benzodiazepines. If you're on a benzodiazepine and you want to do an exposure therapy, it's not going to be effective. So you will have to work with your doctor to go off of those medications before your brain can actually learn and create those new neural pathways that we really want you to do that. You have to get off those medications first and safely. So I hope that you learned a little bit about interoceptive exposure therapy. It's very effective for panic disorder, and I noticed that most people with agoraphobia also need to do interoceptive exposure therapy. So I would love to hear your comments and what you think about it, and if you're going to try this, what your experience is. I'd love to hear people's comments and also what you'd like to hear me talk about. I post new videos every Monday on different mental health topics, and I usually take the ideas that my subscribers give me. So I hope that you subscribe and like the video. And until next time, I will see you in session. Take care. Bye-bye.